Good morning. Welcome, everybody. It's week 3 of our Tackling Type 2 Diabetes series. I'm Jessie Lewis, the clinic coordinator. I'll go through the usual reminders and then turn it over. So most of you are already doing so, but please be sure to chat your name and practice name into the chat feature. I'll go ahead and give it over to our facilitator, Dr. Dungan.
Hi, I'm Kathleen Dungan, endocrinologist at Ohio State University, and I will be facilitating and also presenting in this session. And I would like to allow the other members of the hub team this morning to introduce themselves. Dr. Rao?
Good morning, everyone. I'm Gautam Rao at Case Western, and I'm the director of Cardi-OH.
And Dr. Taylor?
I'm Dr. Chris Taylor. I'm a professor in medical dietetics and also family medicine at Ohio State, and the director of our medical dietetics programs.
And then our case presenter, is Kay Hoops on the line yet?
I am. Can you guys hear me?
Yes.
Awesome. Thank you. So yes.
All right. Great. Welcome. All right, so again, here's just a brief overview of the structure of our clinics. In case you missed this, we'll start off with 5 minutes of announcements and introductions. That will be followed by a brief didactic presentation, and that will be, then we'll have some Q&A. We'll encourage you to, submit your chat questions along the way or during that Q&A. Feel free to turn on your video and just kind of chime in and unmute your microphone at that time. That will be followed by our case study, which will be about 25 minutes, and then our wrap up. And these are our disclosures, and you were emailed those a couple of days ago, or maybe it was yesterday. Next. And with that, I would like to, again, welcome Chris Taylor, who will be discussing lifestyle approaches to the management of type 2 diabetes. Thank you, Chris.
Thanks, and welcome everyone again this morning, our Thursday morning echo session on managing diabetes. This morning, I'm going to talk about diet and physical activity changes within individuals with type 2 diabetes, 3 effective strategies, and some overall impacts of sustained lifestyle changes on outcomes in diabetes. Next slide. So many of the times when we're evaluating diabetes and trying to improve diabetes outcomes, we've got several different factors that all play in terms of how these outcomes develop. And when we evaluate what our treatment practice guidelines are, lifestyle behavior modification is also always one of those that carries across many of the different chronic diseases that we see. The impact of physical activity and dietary patterns you can have on these outcomes. And we have to then balance these around the pharmacologic treatments. And how can we help patients to facilitate both behavior change as well as using their medications to impact their outcomes. So, next slide, please. So thinking a little bit about diabetes and the process of how we increase blood glucose. Blood glucose we produce in our liver and release into circulation, but we also are getting blood glucose as a function of what comes from the food that we eat. So we eat our food, digestion, absorption happens, it goes into our bloodstream, and then this is going to increase our blood glucose circulating in the system. Of course, the pancreas is going to recognize this, identify that we have high blood glucose, insulin response, therefore trying to bring this back down with the insulin receptors and trying to pull this blood glucose back out of the bloodstream circulating, bringing our blood glucose back. But then every time we add a new insult with food, every time we add more carbohydrate into the system, we're now starting this cycle back over again. So we have to figure out what are the processes that are happening in terms of kind of bringing up the blood glucose for our management procedures to be able to kind of bring it back down. So next slide, please. Okay. So as we continue to eat, insulin or blood glucose is going to rise, insulin response is going to happen. And as we start to develop insulin insensitivity, you notice on our little gray radar that we have in the middle, our antennas have kind of disappeared. So with lacking insulin sensitivity, we have the ability for insulin to circulate, but it's not activating at the cellular level and having that impact of bringing down blood glucose. So as we continue to eat, blood glucose rises, insulin rises. Let's click again for us, Rick, please. And then click again. So click again. As we continue to consume more, insulin goes up. We're having insulin insensitivity issues. Also adiposity and obesity can have a negative impact on insulin resistance. So we continue to have this cycle of consuming food, rising blood glucose, rising insulin, but the body's inability to then bring that glucose back down because of insulin insensitivity. So these are all going to start to compound. So it becomes very important for us to assess not only the pharmacologic and metabolic responses, but also what's driving the blood glucose up. What are those sources that are actually contributing to blood glucose? So next slide, please. Okay, click again. Okay. So when we're trying to maintain blood glucose, we have poor insulin production issues. So we have the ability to generate enough insulin. The action of insulin and insulin insensitivity that may be a function of many of the issues, but then also the amount of carbohydrate being consumed. What's pumping into the system? And I always like to describe this in such a way that I know right now we have a hard time remembering what it was like to be warm outside, but it's July, it's Ohio, it's humid, it's hot, and the temperatures have risen. And we need to figure out how can we cool off the building that we're in. So Rick, if you click, please. We're going to turn up the thermostat, or we want to turn down the thermostat. So we want it to be cooler. We're going to turn down the thermostat. We're going to have the air conditioner kick on. We're going to turn down the thermostat. We're going to have the air conditioner kick on. This will typically be effective if we use pharmacologic treatments and other methods to bring down that temperature, bring down that glucose. But if we leave the window open, it's going to be very difficult to continue to control the room because we're trying to use a mechanism to bring down that temperature, bring down that glucose with the air conditioner. But if you continue to let heat in, now you have a bucket that's continually filling as we move forward. So we have to figure out the way to balance between the diet and the lifestyle impacts, as well as our pharmacologic and other approaches to treating diabetes in our individuals. Next slide, please. So we have, excuse me, several guidelines for providing lifestyle behavior intervention to help balance with pharmacologic therapies. Patients will often perceive that the medication that they're taking kind of solves all of their ills in this situation. A lot of times patients will report that, well, I'm taking this pill and it helps control my glucose so I can eat whatever I want, or I don't have to worry about my carbohydrates at this time. So, but many individuals or many patients have been told that it's important for them to change their lifestyle behavior and they should think about changing. And many of them even believe, I think I probably should eat better, but it's something I haven't gotten around to yet. With some of the work that we've done linking primary care patients to nutrition counseling, the interviews with them at the end of the study, they said, I knew it was something I should do, but I never really took it as a priority or something that was important for me to actually act on until my doctor said, I think that you would benefit from nutrition counseling, and I think this is something important for you to consider, and taking that action to get them motivated within the process. So we have guidelines to promote lifestyle behavior. But sometimes patient activation and the ability to facilitate those changes in our environment become a challenge. But a lot of times what it takes is that provider making it a priority for the patient, just as much of a priority as they may think about their medications that they're supposed to be taking, but also taking action on the lifestyle phase. Next slide, please. So looking at lifestyle intervention and its impact on health and disease, we kind of run this dichotomy in the research and in science around healthy eating and physical activity. You ask anybody on the street, what are the things you need to do to be healthy? Exercise, eat right, get your sleep, manage your stress. And everybody says, well, it's important to eat healthy. So that should be one of our central tenets. However, what's the impact of eating healthy? Well, why do we need to test it? Because we already know it's kind of one of our cornerstones. But in the early 90s, the Diabetes Prevention Program was one of the first big studies to take on lifestyle intervention as part of diabetes prevention. Initially, this study was set up to be a test of the drug metformin on diabetes prevention, and it was going to be metformin versus usual care. Well, usual care could mean many things. Is it tell them to eat right and exercise, or is it to actually have them do exercise and eating well as an actual therapeutic treatment? So in this situation, they developed the lifestyle behavior modification group actually as a secondary control group to what usual care should be compared to what usual care normally would be. And as a function, lifestyle behavior modification group was almost twice as effective at being able to preventing the onset of diabetes from, at that time, impaired fasting glucose or pre-diabetes. And the 5 to 7% body weight loss significantly improved health and was more likely to prevent diabetes. But then these also have significant impacts on systolic blood pressure, diastolic, LDL, triglycerides, improved HDL at 10 years out for the impacts of lifestyle behavior on managing blood glucose, in this case, preventing diabetes, but then a cadre of studies following around the actual outcomes in patients with diabetes. Sorry, I keep trying to click. Next slide, please. Oh, back one more. I think we skipped. So, okay, sorry, forward. I thought it jumped twice. So some of our better strategies and thinking about this, I actually had a chance to present to our dietetic students last night in a diabetes course that we're teaching. And even working with dietetic students, I asked them, what are the primary things that you ask about when you're trying to assess diet and trying to assess risk in diabetes and improving glycemic control? And they go to carbohydrate counting. They look for sources of carbohydrate. They look for sources of simple sugars in the diet, and how can they target carbohydrate intakes. But one of the things that are often overlooked is how individuals consume their carbohydrates. What are the meal patterns that they use to consume? What we've seen is we need to make meals matter. In adults, our most commonly skipped meal is perceived to be breakfast, but the data actually show the most commonly skipped meal is lunch. So in our approach to try and spread carbohydrate out throughout the day, we have a decent amount of Americans that skip breakfast. We've got a larger proportion that skip lunch. They have a very large dinner, and then they receive about a quarter of their calories and about 40% of their day's added sugars from snacks, which they're consuming throughout the day. So in looking at distributing carbohydrate out throughout the day, meal skipping is going to have a significant impact on, one, this carbohydrate distribution, but also those who are skipping meals are more likely to have poorer intakes throughout the rest of the day, including refined grains, simple sugars or added sugars, and higher saturated fat intakes. So all of these factors are all kind of linked together. It doesn't mean that replacing meals is going to now make the diet better, but skipping meals becomes a symptom of broader poorer dietary patterns. And we also need to consider not just the foods, but the beverages that individuals are consuming. So snacking time becomes one of these areas where we see a lot of beverage consumption. And beverages are contributing significantly to energy, carbohydrates, and added sugars. And a lot of times people are focused on the foods that they're consuming and have a little less concern about the things that are in their cup. So next slide, please. So thinking about that snacking consumption, I mentioned that about 20 to 25% of adults' energy intakes are coming during snacks. And it's about 40% of their added sugars for the day. So with 20 to 25% of calories coming from snacks, we're basically getting a meal's worth of snacks, a meal's worth of energy from snacks throughout the day. And do we eat our meals as snacks as meals, or do we eat our snacks as kind of snacking sessions, for lack of a better term? But they're more likely to be refined grain sources and higher in added sugars and higher in saturated fats. And what we're seeing here is, of our intakes from snacks, what percent of our calories are coming from what foods? Well, about 50% is from snacks and sweets and non-alcoholic beverages. And alcoholic beverages contributing between 10 to 15% of the total calories from snacking intakes. So when we consume snacks, we're not consuming snacks as meals. I always said that if you were to open up a restaurant and if you were going to have on the menu a dinner, but that dinner would consist of what people ate for snacks for the day, would you be appalled at what was on the menu? Because what would those options be? It's like you can have a dinner with 2 granola bars, a soda, a brownie, a cookie, and a cup of coffee. So focusing on snacking patterns as well gives us the ability to target many of these different trouble areas that are contributing carbohydrate intakes to the day, added sugar intakes to the day, and they're often those kind of non-intentional food choices that have an impact to the broader intakes. So next slide, please. So translating these guidelines into food, the U.S. Preventive Services Task Force recommends a moderate to high lifestyle intensity intervention is needed to really facilitate meaningful lifestyle behavior change. So that means we're looking at 31 to 60 minutes of medium intensity to over 360 minutes of high intensity intervention to really help facilitate understanding the backgrounds of why people consume what they do, how they're making choices, how they can continue to make better choices, what those are relating to in terms of their health conditions, anchored within all their personal situations. So this is going to require a lot of time and effort to help if we want to get people to make larger, meaningful changes. I think it's important to continue to advocate for change and to make it a priority for individuals, but also to be able to kind of consider your scope of practice and your capabilities. I work with Randy Wexler a lot, and he talks about the number of situations that he has to manage within a short period of time with individuals. So the amount of time that he has to dedicate specifically to these meaningful changes gives the opportunity more for referral and being the cheerleader and the support to continue forward for individuals who need that extra time and support to be able to make meaningful changes. And what it's going to then require us to do is to take these guidelines that we have and overlay them within our personal situations for each one of our patients. I think our case studies have been a great indication of how we can take what the meaningful guidelines are, look at what people are eating and have recommendations around intakes, but what's their personal situation? What's their living situation? What's their financial situation? What access and resources do they have? And how can we better facilitate them to be able to make these changes? And a lot of times our recommendations are focused on nutrient intakes. We're looking at carbohydrate, we're looking at carbohydrate counting. But how do we really then translate how much carbohydrate is actually in the food I'm consuming? One of the most common things that I see is the shocked look on individuals' faces when they have a soda and it's a 20 ounce. The recognition of the amount of carbohydrate and the amount of sugar that's in a beverage that they're consuming, and what kinds of changes can they make that have an impact on their blood glucose, that transition from a full calorie soda to a reduced calorie soda, or even going to the non-caloric versions, what that means for them as far as taste and flavor preferences, but also in terms of having those clinical outcomes as a function. So next slide. So I thank you. It gives a chance to get kind of a brief introduction and overview of different strategies that can be used and kind of taking it down to some of the food levels. So I welcome questions, comments.
Thank you so much, Chris. That was great. Just one comment. You mentioned the shock that people might realize with the sodas and the calories. I ordered a drink at Panera a couple of days ago, and the coffees are just unbelievable. So a caramel latte is 400 calories, but if you just get a plain latte with none of the whistles and bells, I think you can get it down to 140. So it is really crazy how just putting that caramel in front of it will jack up all of the calories.
And the perception, if you ask somebody, do you drink sugar sweetened beverages? No, I don't drink sugar sweetened beverages. I don't like soda and that sort. I have coffee. And I put 5 packets of sugar in each one of the coffees I drink, but I don't drink a sugar sweetened beverage. I drink coffee. So the hidden calories that come from those, like the boutique coffee beverages, there was the circulating one around, it's 2 years ago, they had the unicorn, whatever it was, that was just like a bag of sugar blended in a blender. But nobody looked at that as a sugar sweetened beverage because it was a coffee beverage and that sort. So being able to make those connections to the things that you're drinking and what's in those beverages, water is water, coffee is coffee, but when you start adding to them, you're adding to the calories, you're adding to the fat, you're adding to the other things that contribute. So diet or prepackaged meals. We have a question here in the chat. This is one of these, everything that happens in nutrition is Newtonian. Every time you take something out, you have to put something in. We had lots of things that happened with the low fat craze. You take out fat in ice cream, you take out fat and you don't put something else in ice cream, your ice cream is not going to taste good. So they take out fat, they add sugar. You want sugar-free ice cream, you take out sugar, you add fat, because you have to give something to give that mouthfeel. So many of these different products that we see that are, fat-free, sugar-free, this and that, it really requires an inspection of what have they put back in as a replacement for the things that they've taken out. So a lot of times making the sensible, moderate choice ends up being better recommendations than trying to find the no sugar versus the no fat option. Because what happens is when you take one out, it tends to lead to the other, and sometimes it's sodium. So if you have individuals that have high blood pressure and diabetes, looking at these packages for the diet packaged meals, the sodium may become one of those primary contributors that's linking back to one of your other conditions. So how do we use these pieces of information together? Make sensible choices, and I almost say kind of sensible choices rather than erratic choices, It doesn't mean we have to get rid of cake, but maybe we don't eat the whole cake. So now we can keep someone within their comfort zone, give them the things that they enjoy, but do it in such a way that it isn't going to have a negative impact on their health outcomes, and make better choices throughout the way that they are, the way that they're consuming their foods, keeping them more engaged.
I just wanted to remind everyone, during our Q&A portions, if you'd like to participate, we really welcome that, especially if you're able to turn on your video so that we can have a direct conversation. There are lots of great questions in the chat, but feel free to unmute and jump in.
We have a question here about, for individuals who don't like water, there are many different ways that you can drink water complemented. They have a lot of those little like squeeze in things now, or additives that you can have that basically have very little to them. Adding lemon, adding lime, adding cucumber in water. I'm not a huge cucumber fan myself, but additives to water really give you an opportunity to kind of augment the flavor without changing the flavor. But then considering when you go to some of these products that are more like vitamin water, they're not adding just vitamins within the water. They're starting to add, you can see that there's added sugars in them when you look at the labels and things like that. So every time we add the potential for calories. So looking for those meaningful ones that we can add that may provide flavor, that make it something that they'd be willing to drink without adding calories, without adding sodium, without adding preservatives and other things. So.
Great. One more question. Do you have thoughts on what is the diabetic diet? And the reason I asked that is that maybe it was more common in years past. You would see this where someone would say, okay, they need a diabetic diet or an ADA diet. Does that exist anymore? I wondered if you could comment on that.
Yeah, and it's an interesting scenario. We get compartmentalized on many of these kind of diets. With diabetes, we are very concerned about carbohydrate intake and added sugar intake, because those are going to have the direct impact on circulating glucose levels. But there's a broader picture that we have to consider within nutrition and nutritional adequacy. You'll see the DASH diet being used as kind of the answer for a multitude of conditions, because it's a variety. It's fruits and vegetables, it's whole grains, it's low fat protein sources, it's dairy for calcium sources. You're looking at the gamut of nutritional adequacy for all the nutrients we need as a comparison to the individual element that we need. So we might be more focused for sodium on hypertension, and more focused on carbohydrates and added sugars for diabetes. But that still fits within that broader cadre of making sure that we meet all the nutrient requirements that individuals need. Every one of the nutrients acts in our body like a drug, and has an influence on all the different energy metabolism and glucose metabolism storylines within diabetes. So the diabetic diet idea is really starts to boil down to, how do you eat well and meet your nutritional needs while also maintaining an appropriate level of carbohydrate intake and not being excessive that overcomes the body's ability to keep that blood glucose level down. So a lot of times we get into weight loss, and weight loss is all about calories. Well, I can eat 1,000 calories of Oreos and 1,000 calories of iceberg lettuce. Those two are not going to be the same. So where you get your calories becomes just as important as how many you consume. And for the last 50 years in nutrition science, we've been really kind of focused on what's the average calorie for this group and average calorie for this group, as opposed to where they're coming from. So get that appropriate level of carbohydrate intake that will help them maintain their blood glucose while also meeting their broader nutritional needs.
Well, maybe you could address this last question and then we'll move on to the case. Oh, there are a couple more.
Oh, yep.
One more.
Okay. So a question about spreading out carbohydrate and kind of a meal limit. One of the things that tends to happen, especially when we look at the graphs of how people eat, their breakfast is relatively low. Their lunch is kind of here, their dinner is way up here, and then their snacks are kind of filling in the rest of the day. But spreading out the carbohydrate more evenly throughout the day gives us a little bit better chance, especially for those that might be on a long-acting insulin, to have less of those spikes, peaks and drops. So the ability to start spreading that out a little bit more around maybe that 20 to 25% of your calories, 20 to 25% of your carbs and breakfast and then lunch and then dinner allows you to make those spikes a little bit more even, as opposed to a little bit big dinner down and back and forth. So those, we're seeing the same thing with protein intakes being spread out more throughout the day, being more beneficial for protein metabolism and protein status. So that would be my suggestion, being able to spread that out throughout the day.
Well, thank you so much, Chris. If you have a chance, feel free to respond to those in the chat. But I think it's time now to move on to our case. If we could put that up.
This is Jim Warner from Case Western UH, a behaviorist. You know what's interesting, talking about hyperfocus, the patient notices that he's unable to shift his attention. And hyperfocus is a symptom of ADHD, adult ADHD, and inability. It's usually an intentional deficit in executive function deficit, and being unable to shift attention or to remember things that are small details, or to prioritize other things simultaneously, like taking his monitor with him. It could be that it would be worth using a screener for that. There are one-page screeners that are validated instruments. I'd be happy to send that to you if you're interested. And just to take a look at that and see if that could be part of his problem, just in simply managing his diabetes. It could be related to adult ADHD, which is a very real phenomenon. The other thing too is, looking at, as I kind of seem to be saying the same thing many times, so I apologize if I repeat myself, but from session to session, but really what matters to this patient? What are his values? What's really important to him in his life? And if he's a real black and white thinker, you could even, if he doesn't respond to that, what are the rules you live by? What do you try to live up to? And often there's a discrepancy then between what his values really are and his behavior. So if his values are that taking care of my farm, taking care of my animals, these kinds of things are really important. Well, how's your diabetes management fit with that currently? How do those two things go together? And so there's a discrepancy there oftentimes, and it's motivational interviewing technique to simply allow the patient to wrestle with that cognitive dissonance. And that's where we really get the energy for change. And it may not be an immediate one session thing, it probably won't be, but it will be a matter of him going back and reflecting on his own, thinking about this. And then when he sees you again, you can revisit that. And then you could begin to perhaps effect some change, because he's then motivated internally rather than just trying to do things, that you as a provider are trying to get him to do.
Yeah, no, and I appreciate that. And yes, any screening tools, I guess simplified, you mentioned a one page just to get the ball rolling before I try to make a referral from there, I think could be really helpful. I do feel that's a large part of his barriers. I don't know that it's just the disease state itself, but there's a lot more going on for him.
Any other comments?
I'm going to assume that the diner that he frequents is one of these, probably much more like a an evening sitcom type of situation where everybody knows each other and you've got the same kind of servers and that sort of situation. Addressing his eating at the diner all the time gets into just as much probably the social situation for his life as it does the food situation. But it might be one of those opportunities to even there can be other options. You don't have to have fried potatoes at every meal at a diner. I don't know, it might go against the International Diners Code, but I'm not positive. But I think there are opportunities that he can make other choices there. A lot of times it's like you walk in and they know what you want to drink, they know what you want to eat, and they start making it. But even just being able to kind of have the conversation with, they tell everybody everything there. I've been going and I need to start focusing on these things. And it just might be that they have the ability to help with some accountability for them. It's like, I'm trying to do less. I'm trying to eat less. I need to eat less potatoes at every one of these meals. And now it gets factored into what he orders and almost sometimes how they order it for him, as opposed to some of his own choices. It's like, oh, we got some fruit salad in today. That's really good. Maybe you want to try that today instead of this. Then it becomes much more kind of a community situation where he doesn't have to deviate from his normal, whereas others can kind of help him make those changes, especially knowing what they have available and what they can kind of change in the back to make things better for him.
Yeah, and I do appreciate you saying that, because I think that is a lot of his social interaction with humans and not animals does come from that diner. So I was hard pressed to say, try to avoid going, because I think that does take away a lot from him socially. But I did not mention kind of wrapping them into part of his team, to part of his support system, which he is pretty close with them. I don't think that would be a problem.
This is Lisa Keller from Wright State University. I hope my audio is not reverberating. Oh, it is. Just a minute. You know what? I'm just going to type my comment in.
If you mute your computer while you talk, you won't get the feedback in the time when you're speaking.
And so have you seen any reports yet from the Dexcom? I was curious how that's going with regard to his hypoglycemia.
So I have not seen the report yet. He would not use his phone for the app, so I wasn't able to do the share like we usually would. It's all on the receiver. So he's actually coming back beginning of next week to bring that. I have talked to him on the phone just to make sure he was still wearing it. And he did mention there had been a few low episodes, but he was really excited about it, a lot more than I thought he might be. Realizing when it was going to happen was my biggest thing, trying to halt these lows at least a 60, 70 versus going quite so low. So that's something he says he's working on. I would like to see the data myself, particularly, but he said there were just a couple of episodes over the last week.
What kind of physical activity does he have besides his kind of routine care of the animals? Has that come up as part of the conversation?
It has nothing outside of routine care of the farm and the animals. So as far as lifting, a lot of walking, animal care, but nothing purposeful for him. No physical activity that he's doing just for the sake of activity. All very much like lifestyle activity for the sake of getting other jobs done.
Because it almost seems if the farm is a priority for him, you kind of walk out to do the feed, you walk out here. But even adding a routine at the end of the day to kind of walk around the perimeter, walk around, kind of assess, where are fences failing, where are these things happening. Gives them ability to kind of incorporate walking activity. It's not going to lead to a lot of weight loss, but it'll lead to that backdoor of non-insulin dependent uptake of glucose into the muscles. So even just being able to say, what about walking around the farm once each night to see where you've got areas. So it's a way for him to kind of focus on his priority to keep his property in line and identify problems. So I didn't realize the back of the barn was falling in because I'm always going in the front. So a way to kind of survey the land, but also kind of create an intentional physical activity to reduce his blood glucose.
Sure. No, that's helpful. That is helpful.
And I think we finally got the comment in the chat. It says, I've seen that sort of thing work really well involving friends and community. Had a patient with a similar situation. When she actually started talking about how she needed to improve her diet, then, the other people kind of chipped in and were willing to be more helpful. And some of them even started making better choices as well. I love that. I'm not sure how flexible the diner would be, but hopefully, I presume there would be some, more, healthier choices, and maybe that would be an opportunity to bring in the menu to the dietitian to kind of go through it with him.
Sure. And that was her biggest thing too. She really pushed the fiber protein side of things after examining his diet. I know that was a big push for what they spoke of, but neither the dietitian or myself have actually seen the diner menu as of yet. So I'd be anxious to know exactly what his options are.
This is Jackson Wright at Case Western. He has AEs to a large number of potentially very useful glucose lowering agents. I was just wondering how, the AEs are certainly real to him, but I guess the question is how have you had a chance to assess whether or not they may be able to assist him in managing, are those AEs really such that these drugs he cannot use, or might there be a possibility of revisiting some of those agents?
Sure. And I'm with you on that. I do agree that I think he could have given some of them a better trial. The GLP-1s in particular, as soon as stomach upset arose, which we did talk about, this was not a surprise to him. We certainly went over that ahead of time. But when those side effects arose and he didn't feel well, then he immediately has these complaints of, well, I didn't feel well and the animals needed things and I didn't want to deal with that. Or the SGLT2, he actually reported an increase in hypoglycemia levels, which I was really surprised by because we did change his Novolog levels initially before we started that medication. So I wasn't expecting lows like that. We started at the 12.5. We talked about the hypotension possibilities. So I really thought he was prepared for that one as well. But he had a few lows that he stated to be more intense than his typical ones. And again, that trial lasted only about 3 weeks. So either one, in my opinion, would warrant a retrial. It's just getting him on the right page to be willing to do so.
Okay, sure.
And then another question in the chat, would it be appropriate to increase the basal insulin to decrease the need to use mealtime insulin, then decrease the basal as diet improves? Thoughts on that?
Yeah, and I think, so that was another one of our starting out conversations. For the longest time, when I first started working with him, he was under the impression that the basal insulin was more cause of low sugars than the bolus insulin was. So he actually felt much safer using higher doses of Novolog than the Lantus. So that was a habit we worked to break in the beginning. I certainly would go slow with him just because he is so gun shy of that. But I think increasing basal insulin would be a really good thing for him. Sure.
Yeah, and since he's had diabetes for so long, and his weight his body mass index is in the normal range. I mean, it's still, you know, likely type 2 diabetes. He probably still has residual C-peptide, but that might be something also to think about before, you know, giving him a promise of, you know, you would be able to stop insulin, which you probably wouldn't at this point.
Sure.
Okay, so we are heading up to the top of the hour, and I would like to transition to our wrap up now. Jesse, could you bring up that slide?
Sure. So yeah, thank you everyone for a great discussion today. I'll just go through some reminders here. So you are able to watch all the recordings of the current clinic on our website, cardio.org. For the current clinic, you would just need to make an account on our website, but you also can view any of our previous Cardio TeleECHO clinics as well. And then thanks, Rick. Also, the usual post-clinic survey is in your inbox. Everyone's been really great about providing feedback, so please fill that out for today's session. It will close tomorrow at 5 p.m. And just a reminder, there are CME credits available for this series, and we will definitely be providing more information on how to claim credits as we continue and get to the end of the series. And then lastly, just a reminder, Cardio is hosting a webinar February 10th. It's from noon to 1. It's free to attend. There are CMEs available for this as well. And there's a registration form on our website. And with that, I think we're good for today. So again, thanks to everyone for participating, and hope you have a great rest of your day.